Pertinent, and I think the whole point of what Jasna's done is to be concerned with contextualizing. So the focus of the work is psychiatric drugs, but that's not the focus narrowly that we want to be concerned with. We're also concerned with the hows and whys, but we're looking at that at the time of the 70th anniversary of the UK National Health Service, and I personally haven't seen a bad word written about the National Health Service in the places that I look at about the 70th anniversary. Mostly congratulations, but mostly I've noticed assuming physical health. It's not really been a conversation that's particularly focused on what I would see as the seriously problematic zone of mental health services within the NHS, which we know make up a major part of its responsibilities, which we know are an increasingly poorly funded area of that. And one of the things we also know, of course, is that since the 1950s, for example, when there has been unbelievable change in what we might see as physical treatments within the NHS, one thing that has been a continuity in mental health services has been increasing reliance on drugs, the concern of today's discussion in one sense. And that made me think about another area of my interest, which is end-of-life care. And it is interesting that all the work that I've been involved in about end-of-life care has respected the incredible contribution that drugs have made, particularly in countries like the UK, to pain control. And this is something that's been greatly valued amongst patients and their families, and has particularly been advanced, I think, in the voluntary sector. There is enormous contentiousness about this area of activity, particularly from countries like the United States, where there seems to be an overlap of understanding about the kinds of drugs you use for pain control and drugs that are seen as dangerous and also threatening. So that the debate is skewed there, but only for that reason. And I think that's interesting, how different the discussions are, even the prevailing discussions. And it's that part of the context issue, but part of the broader issues, which I think make it so important that we're here in this room and beyond the room, to be able to have this discussion about what I think, and I really agree with Thomas, a very helpfully and clearly and unpolemically written report tries to do to help us understand what's said about drugs, what people feel about them, who may be on the receiving end, and where we might be heading. The sense that maybe there is a real need to be doing some moving on in terms of the discussion and who the discussants are. And then, of course, occasions like this and who's here, virtually or in presence, is going to be very important to make that possible. So I want now to hand over to Jasna and to introduce her very briefly. Jasna will speak for 20 minutes. Jasna, who I've known for a while now, who I greatly respect because of the strength and decency of her intellect and her efforts to bring good change and make sense of things, is someone with, I think, an international repute in this context as a survivor researcher, as an activist. I don't think I should be saying any more. Over to you, Jasna. Thank you.
Thanks. I hope that you will be able to hear me because I'm a bit lost without microphone. Can you hear me? I have a very low voice, so yeah? If not, just tell me. Okay, firstly I want to thank McPin for initiating the Taking Point series, and particularly the way they've conceptualized it. Inviting first-person voice to articulate itself in mental health and psychiatric research on its own terms and away from the agendas that dominate this field does not happen very often. And even less likely to find our means and resources allocated to support and enable that to happen. So however limited the talking point papers in their scope and reach may be, I hope that the importance and the value of this very approach will gain more recognition and will eventually be adopted by other research organizations and institutes. I'm delighted that the paper is now being launched, but also overwhelmed, as I'm not really used to my work being promoted. And when it gets promoted, then there's a flight delay. What makes me very happy is that the two first readers of this paper and people who greatly encourage me, Stephanie and Peter, can also be here today. So my special thanks goes to Thomas and Kat from McPin for all their work and engagement in organizing this event and making Peter's and Stephanie's participation possible. I'm now supposed to briefly take you through the paper and was strongly advised not to rely on people having had time to read it in advance, but still I'm curious to know whether you had a chance to read the paper, or at least the summary. Like, how many people read the paper? Okay. Okay. In the next 15 minutes or more, I will focus on few things that I find the most important, but will also use the opportunity to give more background and share some more thoughts and feelings that are not necessarily in the text itself. Initially, I actually wanted to write on a different topic that is closer to my PhD research, but because it didn't really appeal to McPin, drug research was my second proposal. Given that service user involvement in this field is scarce to non-existent, Thomas and I agreed that this was a timely and sensible topic to pick up. At that point, I had no clue how difficult it would be to actually write about what seemed like a logical and straightforward matter to elaborate on. The paper started under the working title, Making Room for Experiential Knowledge in Research on Psychiatric Medication. But when trying to think in terms of our inclusion in this research field, I was only seeing impossibilities. As those impossibilities do not involve easy to remove barriers that would only require goodwill, but instead are deeply embedded in the tradition of knowledge making in this field, the conclusion I came to was that there was actually no way to genuinely include experiential knowledge unless the understanding of research and research conduct fundamentally change. I simply could not argue for more room for our perspectives within the confines of the dominant approaches and methods of psychiatric drug research. Those confines do not only work against experiential knowledge, but also exclude any other approach that doesn't fit the biomedical paradigm which treats madness and distress as physical diseases. The contradictions and ultimately the impossibilities that I encountered in thinking through this topic are at the same time the main message that I hope this paper will communicate. That is, if knowledge making about this central issue in the lives of people diagnosed with mental disorders is to open up and truly integrate perspectives of those who have first-hand experiences with these substances, or what I call first-person knowledge, then it needs to change substantially. This demand for fundamental changes in evidence-making about psychiatric drugs is what I then try to capture with the change title and the expression redirecting research. Another challenge of writing this paper was to find the right position to write from. This might sound strange, as I'm of course full of opinions and certainly don't lack my own stance on psychiatric drugs. But I wasn't interested in promoting that stance because I don't think it matters. What matters instead is that each person's individual stance counts when we come in contact with mental health services or when they come in contact with us, and that each person is given space and support to explore different paths and find our own best ways to lead our lives. So the work on this paper forced me to bring us all on one side, regardless of how we individually see the use of psychiatric drugs, and focus instead on how mental health systems respond to us, and more specifically the kind of knowledge that those responses are based on or claim to be based on. I wasn't writing in anybody's name or aspiring to represent any particular group, so the position I ultimately found to write from was at the level of where our diverse experiences and struggles meet. Experiences of taking, refusing, or being forced to take drugs, of coming off or contemplating coming off. It took me a long time to reach that place to write from, as this kind of effort is very different from my activism within what I see as a profoundly divided movement of people with psychiatric experience. So here I have to give my big thanks again to Thomas, who was very patient, tolerated several delays, and altogether showed understanding and respect for the time this paper needed. The introductory part that I called preliminary notes give some insight into how I approach the writing and outlines the scope of this work. My hope for today is that we broaden the discussion, but possibly not abandon its main scope, which means avoiding a heated pro or contra drug debate, how best to come off, or whether there is such a thing as mental illness. Even though these issues are much more pressing and closer to people's lives than the apparently dry and abstract field of research, I would really like us to stay with the question of evidence-making about psychiatric drugs and explore how to disrupt its dryness and bring it closer to our lived realities and in our own interest. I started the paper by placing the topic within a human rights framework and making it clear that treatment with psychiatric drugs has gradually left its exclusively medical realm. This has happened irrevocably with the adoption of the UN Convention on the Rights of Persons with Disabilities in 2006, signed and ratified by numerous countries, which are now supposed to bring their national legislation, including mental health laws, in line with the provisions of this international human rights treaty. I tried not to focus only on clear implications of the CRPD on forced treatment with psychiatric drugs, but also to include some other documents, such as last year's report of the UN Special Rapporteur on the right to health, that is very critical of over-reliance on drugs in service provision, as well as the related prevalence of biomedical research. So there is a big gap between our declared right to a different kind of response when going through madness and distress on one side, and the reality on the other that far and wide there are no other responses in place, and drug prescriptions remain the first and most often also the only answer to the multitude of our problems. In effect, making use of our declared rights is a different matter and demands major changes in the organization and philosophy of services, as well as in education and training of their workers. In my opinion, this should have clear implications for research and for the allocation of research funds. It is unlikely that further investments in current drug research are up to the task of informing, let alone leading such fundamental changes. In the middle part of the paper, which is also the longest, I examined the main limits of psychiatric research and tried to expose the incompatibility of first-person knowledge with conventional drug research, including quotes from personal accounts that demonstrate how drugs do not only enter our bodies and minds, but our entire lives and shape our biographies. I explored what stands in the way of first-person knowledge becoming a valid epistemic source. The things that most obviously stand in the way include narrow research questions, simplified criteria to measure treatment success, and monological interpretation of the outcomes. I also extended the notion of knowledge production beyond research and argued for the value and consideration of sources authored by people who have experienced madness and distress, together with its conventional treatment, and are committed to challenging the dominant approaches and seeking different solutions. Those sources go far beyond personal accounts and include advocacy, research, and theoretical work, as well as alternative concepts of support. I was able to provide only a rough sketch of such sources that specifically focus on drugs, and I will use this opportunity to add one exciting development in the US that started in January this year, after my talking point paper has already been finalized. The Inner Compass Initiative. Do people know about this? Has anybody heard? Somebody? Okay. This initiative, the Inner Compass Initiative, is directed by survivor activist Laura Delano, is a web-based information sharing and connecting platform that, and now I'm quoting from them, strives to contribute towards everyone reclaiming wisdom, knowledge, and power, both within us as individuals and between us in our relationships and communities. We work to support individuals to engage in curious, critical, independent self-education and inner exploration, and collectively to help develop more interconnected, empowered, and resilient grassroots communities. End of quote. I find this initiative greatly relevant, among other things, because it places the topic of drug treatment on a different ground and recognizes that achieving different responses to madness and distress will need to involve whole communities and cannot be delegated to any single specialized profession. In the final part of the paper, I took a closer look at the potential role of research and its power to foster such paradigm change. As I couldn't really come up with any feasible suggestions on how to fix or improve psychiatric drug research as it stands today, I chose to elaborate on few things in research that I see as a matter of principle. In retrospect, I see this final part as embedding some features of med studies, an emerging field of activist scholarship that I did not mention in the paper itself, but wish to mention now, not only because this piece of work belongs there, but also in order to highlight the unique prospect of med studies to both shift our understanding of madness and distress and inform our action regardless of where that action takes place. In the words of the editors of the first book to introduce this field, published in Canada 5 years ago, med studies can be understood, and I'm quoting, as a project of inquiry, knowledge production, and political action, devoted to the critique and transcendence of psi-centered ways of thinking, behaving, relating, and being. The abbreviation PSY, which is PSY, is meant to cover not only psychiatry but also other related disciplines such as psychology and clinical social work. So what I attempted to do in this last section was to take the administration of psychiatric drugs out of its narrow medical context and open up the task of knowledge making on this issue to more perspectives, including first-person perspectives. So far, research on this topic has focused almost exclusively on individuals taking or supposed to take psychiatric drugs and their reactions. This approach, which is also typical in research that is critical of drugs, greatly neglects the fact that these substances do not only enter individual bodies, as none of us lives in a social vacuum. Drugs intervene also in our relationships, not only the relationships that are supposed to be helping, but in all other relationships of our lives and the social world we inhabit. And even more, psychiatric drugs also define and co-create those relationships. They also produce and separate groups in social spaces that we are meant to share. Drug administration is indivisible from structures where it occurs, including the broader socioeconomic, political, and also historical context. The few suggestions I make in this closing part of the paper about potential ways forward can be subsumed under the phrase inverting the research gaze, or what Canadian survivor scholar Lucy Costa terms flipping the microscope, a move distinctive to med studies. This means that rather than further investing in microscoping people's reactions to drugs and comparing our characteristics to social norms, third-party criteria, or scales, it could be about time to shed much more light on prescribing practices and prescribers, as well as on all the other circumstances of voluntary or forced administration of drugs. Such a change of research direction would signify a huge qualitative shift in this whole enterprise and could also foster and accelerate the inevitable paradigm change in responses to madness and distress. However slow that process of change may be, and despite the amount of resistance and also sabotage from various establishments and their temporary successes in extending coercive drug treatment, it is clear that the project of emancipation, and if I may use that old-fashioned word, liberation of people currently diagnosed with mental disorders, can't go backwards anymore. So in my opinion, research can either join that process of change and importantly contribute to it, or it can continue to delay and obstruct it. People going through madness and distress have been extensively studied. I think the time has come for us to pose questions and invert the microscope. So for example, while there is already plenty of evidence about the desired and undesired effects of drugs, there is a serious lack of knowledge and vision about what professional support could look like at all, if not always relying on drugs. There is also a subtle difference between the topic of withdrawal and deprescribing. Even though these two topics can be seen as two sides of the coin, it is usually one side that wins the research bids. In this case, it will be withdrawal, because it continues to focus on patient and patient's reactions, whereas deprescribing would unfamiliarly broaden the focus of research and involve seldom asked questions. That brings to mind Mike Oliver's understanding of research as social production, meaning research in which, I'm quoting, we produce ourselves and others in differing ways from those we have produced before. End of quote. In such research, impact making is integral to the overall process. It is something that occurs throughout research rather than afterwards, if at all. We need projects brave enough to engage with reality outside of research institutes and take on those difficult questions about how to change praxis. As the Canadian sociologist Arthur Frank reminds us, what we need is a shift, and he says, a shift from needing more knowledge to needing values that allow us to take a stand with respect to what we know. I have pointed to some already established research findings that need to be acted upon rather than further experimented with. Those findings include the over-medication of people of color, the prevalence of antidepressant drugs in suicides, or the lack of prescription monitoring in private practices and non-residential psychiatric services, etc. These are only some of the issues, but I didn't mean to suggest them as just additional research topics. To me, equally important is how the research process is understood and designed. As long as the research conduct stays within the dominant paradigm that clearly divides the observers from those to be observed, there can be no change in sight. I hope this paper will spark more debates in different directions and generate courage for new and unexplored collaborations. Thanks.
Thank you very much, Jasna. What we want to do now very quickly was to see if there were any specific points of clarification that people wanted to raise with Jasna. Not to begin the discussion more generally at this point, but if there was something that wasn't clear, if people would just raise it and then we can get a response to make sure none of us are unclear about what's been said. So has anybody got any such question that they'd like to check out with Jasna? Anything for clarification? So the answer seems to be no. So you were clear. Now we move on to Stephanie and Derek. Do you have a preference, either of you, in which order you go? Should we go for variation and have Derek?
If you prefer.
Would that be all right? Right.
Sure.
Just before you start, I've got these biogs, which I'm trying to sort of abbreviate. They're really nice biogs. So Derek is a consultant psychiatrist and clinical director in Oxley's NHS Trust. He's clinical lead for a London borough that's tried to bring together physical health, mental health and social care into one organisation, which sounds genuinely interesting and helpful. He sits on the editorial board of the British Journal of Psychiatry, leading its social media work. He's trustee of the charity In Your Corner. There were some interesting contradictions for me here. This is concerned with building self-confidence, self-esteem and social contact, as well as fitness in individuals who've suffered from psychosis using boxing training. I was beginning to think about brain damage and boxing training, but we won't go into that. But he's very candid. He hates butter, cats and whinging. I don't think there's a particular order. And he likes running, the stone roses and enthusiastic people. So be careful if there's any unenthusiasm in you. Perhaps not today in front of Derek. Derek, over to you.
Thank you. I've just written down some things I hope to talk through today. It's a real pleasure to be invited here. I've been reading the document over the last few days, and there's little to say beyond that. I think it's a wonderful piece of work, and it's incredibly timely. And I think there's a need to recalibrate what we do in healthcare and in research and in terms of medication, but in terms of health more generally. And a word that came up when you were talking about was social, and I might come on to it a bit. Some of the work we're doing locally, I see it as part of a social enterprise and being part of a community and trying to move what we do away from focusing on medication. But there are a few parts, I wanted to pick out a few phrases that just resonated with me from the document itself. And one of the phrases was, medical science has a long and deep-seated history of involving patients solely as research subjects. And I think that's true. And I don't think that's unique to psychiatry. I think that's something that healthcare and medicine has done. It has historically had a patriarchal, expert-based approach to well-intentioned help people, but it's seen people who use services as people to do research on rather than with. The idea of social positioning, I think that's something we've not been good at. I think it mentions within the document about checklists of questions, and not, to me, not seeing wood for trees with people in their lives and their environments. The other things which I'm hoping today draw out, that ideological debates tend to omit complex truths and struggles of those who take or do not take these substances, which I think is true. I think that there's always a danger in discussions that we get into binary positions on things. And the other thing which I'm mindful of today is there was a phrase within it that said, searching for the right words is at the core of our infinite journey towards understanding our world and the world we live in. And we probably all come at things from our own background, and I will say things using language from my training and my experience and where I grew up. And I think words and phrases matter within healthcare, but particularly within mental health care. I had a few thoughts in terms of research and in terms of what we might do. In terms of research more generally, I mean, it's been a sense of mine for some time that we're entering what I would call a post-RCT world. So RCTs are randomized control trials, and they've been a gold standard in science for a long time. And they have lots of strengths, and there's a reason why people like them. But they have enormous limitations, and I think it's coming more to the fore. So I don't run a clinic just for right-handed males aged between 18 and 65 who've never used substances in the past. But that's what RCTs are based upon, and it's based upon a very narrow view of the world. And I think we're getting to a point of science stretching beyond that, and I think there's a growing recognition of that. And I think it hasn't gone far enough. And I was thinking on the way here about some of the work we've done. So I'm interested in experience of people who use our services. And a couple of years ago, I worked on what's called a crisis team or home treatment team. And we did some qualitative research on the experiences of people who use the home treatment team and day treatment team that I work in. And it was interesting for a couple of reasons. So if you do any research, one of the things you'll be aware of, to publish research, you have to do something that's new. You have to advance science. And what we did that was new in 2017 was we asked people their opinions, people who use the services. And it was kind of shocking. That was published because no one had done that. That was last year. And that's not to dismiss anyone or anything, but it gives us a bit of a calibration of where we're at. But to me, so my take as a psychiatrist when I read the document is that that's fine, but it's not far enough because it's still me asking those questions. I did it with my MSc student from King's and we did some work, but it was still, again, maybe the microscope was me asking other people, how do you find the services that I give you, which is probably still needs to be inverted around. I think I agree. The biomedical approach, so I'm a doctor and I'm a scientist and I'm interested in brain cells, I'm interested in biology, but I think the problem is biopsychosocial is always the wrong way around. It's socio-psycho-biological. It's not as easy to say. And that we experience our life, and if we think about the world around us through the social and the psychological, and the biological is a small part. There's nothing wrong with the biological, but I think maybe even the language frames it by starting off biologically, and that needs to change. And the other major thought for me is, I think when we ask what works, I always think it's a silly question. When people say what works for this, because there is a multitude of answers. What helps people in different situations? And some figures for me that always provide context. Now, anytime anyone gives you figures, it's pulled from a paper somewhere and they're rounded, so you can criticise them, but figures that stick in my head from some work we did in the British Journal of Psychiatry a while ago that was published there. And again, it's not my research, and it could be criticised. They were US figures, and they suggest that 3 out of 4 people who took antidepressants didn't have depression. And that's really interesting, because what's happening with the 3 out of 4, because I don't think they were undercover investigators from Panorama, they were people with problems. People were saying, there's something not working in my life, and I'm asking for some help, and that was an answer they were given. So we've got to be careful about what that means. That doesn't mean 3 and 4 people are going inappropriately. Maybe they've been given an inappropriate answer. But there's another figure came with that, and that was 3 out of 4 people who have a diagnosis of depression, and we can, you could challenge diagnostic systems. But 3 and 4 people who had a diagnosis got no help at all, got nothing. And about a third of people who do get a diagnosis get no follow-on care. And there's something quite complex in there that it needs complexity and nuance about thinking what that means. And that's just taking one bit of the world, and that's just taking one set of figures. And I was talking to Peter before this, and where he was asking me, I think, a bit about my background and where I work and where I'm from and what I do. And the thing that interests me today, I suppose, is, so I'm the least qualified person to say next steps, I think, in a sense, because if we invert the microscope, it shouldn't be me asking those questions. But the managerial work I do within Bexley, which is part of Oxley's in South East London, it is, to me, I'm quite proud of where we work and what we do. And I do see it as a social enterprise. That, as Peter mentioned, we have merged physical health care, mental health care and social care into a single organisation now. And if you come to see us in a large clinic or community centre, this will be starting 2019. There's just lots of people there with different jobs and different skills, and it's part of a wider society. So we have a Twitter feed, Bexley Care, and we're part of Bexley Life. It's about involvement with lots of other things. And I guess the question I have for myself with, and it might be something people want to discuss, I don't know, is how do organisations take a stance, and how do you shift culture on this? Because there's recalibration, so I think part of it is science and scientists, and maybe while professionals wanting to neck in a bit, but there's something about cultural change, and I think that's quite hard to do in an organisation. That's about how people feel and believe in what they do. So I had this stuff we're doing locally, but maybe it might be better to put it to questions about that people might have later on. I mean, very briefly, within where we are, how we're trying to invert it slightly, which is, it's a work in progress, and we haven't fixed it. There are 3 arms for me within our organisation. One is we have a group called ResearchNet, and within my organisation, that's people who've used services and help co-design what we do and set out research questions. So a recent example, I was thinking about it when Jasna was saying at the end about what questions are next. We had a member of ResearchNet who said, well, I use a medication called clozapine. I want to go back to my GP. You guys are nice, but I don't need to see you anymore. But the system doesn't allow me to do that. And how do we build up the ability to do that? So that's leading on a question that could never have occurred to me, because it didn't enter my head. The second thing we're trying to do is we have a thing called a LEN, which is the Lived Experience Network for staff who've had mental health problems, as a sub-organisation within Oxley's. And one of the things I think has been really groundbreaking for us has been what's called our Lived Experience Practitioner Network. So you can kind of hashtag LXPs or Lived Experience Practitioners, where as an organisation that we are obligating ourselves to hire and involve people who've had past lived experience of health problems, mental health problems, physical problems, be part of the organisation, kind of diversity of thought. Because to me, it's kind of, it's a bit of a hacky phrase about big tent, but you kind of need lots of diversity of ideas because it can't be driven by me. And so I'm reiterating a bit, but my thought is, how do you get cultural shift in things like the NHS or big institutions? Because it's hard. That's my...
That's it.
That's my bit for now. I'm happy to...
Thank you, Derek. And just to give everyone the same chance as was offered in relation to Jasna, anything that anyone would like to just check out with Derek around clarification? Diana?
Yeah. Did you say, sort of in the middle of your talk, that you did work in 2017 asking service users what they thought of services, and this was the first time that such qualitative work had been done? Because it's been done by people in this room
Well,
for 30 years.
Yes, no, but to clarify, so part of it was based on, and of course the work was published in 2017, so it's before then. It was a type of qualitative analysis within a specific type of team called the home treatment team, and one within day treatment, which is published this year. There has been other types of work done within it, but there was novelty to what we did within a standardized home treatment team. I mean, it may be slightly beyond a specific conversation here. I don't know. I'm happy to answer questions on it. I'm not trying to push it aside. But again, it was published based on the novelty of what we did with a more typical group of people who use that service.
I just don't agree with you.
Okay. Well, I mean, the work is published, and that was the basis of publishing it.
I won't continue, but there's lots published by people in this room, by McPin, by the three people sitting next to you, that are doing that kind of work.
Oh,
work published in the British Journal of Psychiatry.
yeah, I did invent qualitative research, and that was a type of work we did within the community mental health team.
So I think we've got some clarification if we haven't got any agreement. Anybody else? Anybody else? So thanks then, Derek, and it's now over to Stephanie. And Stephanie, who I was privileged to meet earlier this year in France in her other role, which is as a really terrific translator, but trying to compress her biography in a way that's helpful and quick for all of us, who's devoted the last 20 years of her life to advocate for the rights and interests of service users and ex-users and survivors of psychiatry, volunteered and worked with a number of French national user organisations. She is originally a US national. Involved in European level survivor organisations, including ENASP, the European Network of Ex-Users and Survivors of Psychiatry. Also, as she advises us, more recently involved in research projects. So, also has an interest, I think, particularly in the UN and its concern with people's human rights. Over to Stephanie, thank you.
Thank you, Peter. So first, I'd like to thank the McPin Foundation for supporting this type of opportunity in research and for your invitation. I'm honored to represent ENUSP, the European Network of Ex-Users, Users and Survivors of Psychiatry, which is the only independent network exclusively composed of persons with lived experience. By independent, obviously we mean not funded by the pharmaceutical industry or other interests, and therefore in a position to observe the situation objectively by listening to what our members have to say. Jasna's contribution along these lines as a member of ENUSP has been especially useful for us. ENUSP wholeheartedly supports user and survivor research. When Jasna told me about her theme of redirecting research and our potential involvement in this area, I thought to myself, wow, that would really require a lot of redirecting. Could it be possible for mental health service users interested in drug treatment to dictate research agendas, as has slowly become the case for much more powerful consumer movements? Considering the huge weight and impact drug prescriptions have always had on persons in psychiatry, it should matter considerably. From local self-help groups to almost any gathering of users of psychiatry worldwide, the issue of drug treatment and all the related questions always come to the table at some point. Unfortunately, this issue can become an obsession for people. Many users of psychiatry live in fear of taking or not taking psychotropic medication. Their lives for this reason can be unfairly reduced to having an identity of psychiatric patient. This was my own case for several years. Many of us here probably know what it is like to be placed under heavy drug treatment, to live like a walking zombie, barely capable of moving or thinking, much less reading, working, or engaging in life. Fortunately, in my case, I found a psychiatrist who offered me choices and then respected and supported my choice to stop taking psychiatric drugs. I found other solutions that work for me, which allowed me to get my life back, as many of us have to say. But having a choice appears to be less and less often the case in psychiatry. In spite of the UNCRPD and the documents cited by Jasna, the principle of free and informed consent and choice in terms of psychiatric care, as should be the case for any kind of health care, seems to be more and more widely ignored. With the spreading of community treatment orders around Europe and more people forced to take monthly depot injections of neuroleptics or other medications in the community, users of psychiatry can do nothing to control their treatment, and much less the adverse effects. In France, a much greater focus on security over the last 10 years has led to an increase by over 50% in the number of secure residential intensive care and prison psychiatric facilities, where treatment is dispensed without question. Exacerbated by recent terrorist events and economic disparities, there has been an even greater psychiatrization of the social, as we put it. There seems to be no other area of prescription care where the consumers themselves have such little power of choice or influence. This also includes people who feel that medication saved their lives, or who prefer to take psychiatric drugs permanently or from time to time. Perhaps one way to improve this situation could be our involvement in research. As Jasna says about free and informed choice, quote, "In order for choices to be justly informed, responsible, comprehensive, and accessible research on psychiatric drugs is indispensable. And in order to be able to talk in terms of choices at all, there have to be other options than medication available, or at least the option not to take it." Moncrief's avenue of research, she presents, which states that how useful a drug or other therapy is depends on a person's unique circumstances and subjective experience, does seem to be a way to improve prescription practices. And I would add de-prescription practices and therapy recommendations and access. This could also lead to more research on the huge impact of the placebo effect, for example, a low-cost solution we've known a lot about for years. At the same time, the risks of perverse effects in research brought up by Jasna, just as we have seen with certain one-size-fits-all recovery approaches, deserve particular attention, such as experts by experience in danger of being reduced to another commodity rather than working on contextualized forms of research, where criteria used to measure treatment outcomes are based on what ultimately matters to each one of us and our own potentials, aspirations, and dreams, as Jasna says. Treatment or care could and indeed should be judged by its ability to support us in finding and realizing those opportunities. I hope that Jasna's call for true leadership of experiential knowledge in drug research, based on the principles she's outlined in her paper, will be heeded, and especially as a starting point, our own experiences on a much broader level. So now I wanted to share with you my very recent experiences in research opportunities. As Peter said, I have worked for the last 30 years with a few interruptions as a translator and conference interpreter, simultaneous interpreter. And through that, I gained a lot of experience with mass market consumer research, translating guides, translating reports, interpreting focus groups. So it really was not unfamiliar territory to me. And then I've also translated more technical articles for French professors and researchers in psychiatry and social sciences. So it started to seem to me more and more that research could be a similar occupation. Even if you have to do all the groundwork to collect all the data, you do listen to people and then you interpret what they say. So in the beginning of 2016, I was asked to provide a commented bibliography on user survivor research for a research action application submitted by Advocacy France, which is the main organization I work with in France today. And in the end, I spent much more time than I expected. In fact, months and months, finding, and then I couldn't resist reading and summarizing in French a vast wealth of information on survivor research that I was only slightly aware of. I was amazed. And Jasna was instrumental in pointing me to the road ahead, and I learned with great interest about the work Peter Beresford and many others here in the room have done. So I was not interested in continuing with this first project because it was essentially led by professionals to find ways for service users to speak out and who are not treated as equal shareholders or stakeholders. Then in the beginning of 2017, Mental Health Europe, I'm a former board member of, started working on the European research project Shedding Light by obtaining funding from the Open Society Foundation. This project is looking at transparency issues between the mental health sector and the pharmaceutical industry. The main objective of Shedding Light is to raise awareness of the importance of transparency in the field of mental health and to encourage the adoption of sunshine and transparency laws across Europe. One focus is on the ways marketing budgets are used to pay professionals to promote particular products and to influence the publication and the interpretation of research results. This has led to a lack of fully informed choice for doctors and patients, over-medicalization of mental health, and a worrying reliance on drugs as the main form of treatment, as we've heard again here today. I could tell you more about this project if you're interested. And more recently, in March of this year, I decided to go for it, and I set up a research team with two professionals much more experienced than I am in France, but that I respect greatly, that I've worked with before, to submit a quotation to complete qualitative field research in France on disability-specific forms of deprivation of liberty for the Center for Disability Law and Policy at NUI Galway. The results are actually going to inform the next report delivered by the UN Special Rapporteur on the Rights of Persons with Disabilities in next March. So it thrilled me that we could be awarded this project, and the dynamics of my relationship now with these two researchers has been unfolding over the last few months, and it's been very interesting. Now, obviously, this is not, quote, survivor research, but it is definitely informed by my experience. Initially, I could tell these two professional researchers were a bit afraid to trust me, in particular with VIP policymakers being interviewed. Knowing me as an activist, they were probably worried I'd come out with some totally radical, vindictive statements or something, rather than listening, understanding, and probing on what the interviewee had to say about deprivation of liberty. These researchers were also tempted to stray away from the premise that this is disability and CRPD-oriented research and not an issue of mental illness and incapacity. But I was able to really turn them around there. And I also know that the wider knowledge I have of the mental health landscape and players in France has been very useful. I'll give you one last example in connection with this study. when the question of restorative justice came up for the first time, the respondents and the other researchers could only see this from the point of view of a mad person having committed a crime against a victim. By mentioning to them that this could also be the case from the other side, that victims of psychiatry could be asked how they would like to be compensated for the violation of their rights in the form of paid education, housing, or employment, for example. This is already reversing the roles that stopped and made these professionals think. So this learning by doing experience for me has maybe already been impact making as an, quote, integral part of the overall research process rather than afterwards, as Jasna suggests. But I hope that the impact of this type of research on our lives afterwards will still be what I would hope for the most of all. Thank you.
Thank you, Stephanie. And finally, any specific particular points for clarification in relation to what Stephanie's been talking about? Thank you.
I wasn't sure what CRPD was standing for.
Thanks.
CRPD?
It's the Convention on the Rights of Persons with Disabilities that we mentioned a few times earlier, the United Nations Convention. And are you familiar with this convention? People in the room, I think, or...
Would you like to just say a little bit more
It's
about it?
worth
I think the most
discovery.
important is it covers people with psychiatric diagnosis because it refers to people with perceived disabilities also. So, I mean, people with psychiatric experience are covered by the convention. It's International Human Rights Treaty, first signed, and then ratification means that countries who have signed, you correct me if this is not my field, they need to bring it to harmonize their national laws to be in line with the convention. And the convention is important. It came about in 2006. Many people with disabilities were involved, and many organizations, and also people with psychiatric experience were involved in drafting the convention. And one could speak a lot about the provisions, but there are some really important provisions that concern our lives, such as prohibition of forced treatment. Not everyone interprets it that way, but that's what it says. Then issues around legal capacity and many other issues around deinstitutionalization, etc. So, and then even more, there's this committee that that examines the countries,
that conducts a review of the countries.
Conducts a review, so the representatives of government are called to Geneva in certain, and I know for Germany because that's where I live, and are answering questions. And anybody can also submit their reports to this committee. And it's a good mixture of people, the committee, people with disabilities also. And they are, this is not very popular. I can speak about Germany, the law that enables for treatment is still there, and I don't know how long will it take it to. It's not going to be abolished tomorrow, but there are these processes in place, etc. So it's moving. It's a very important document for us.
And in addition to the convention itself, there are the interpretative documents called general comments, or even the guidelines on Article 14, which has to do with liberty and security, i.e. forced treatment and hospitalization, that I'm sure you would find amazingly inspirational. When I first started reading these UN documents, I thought, wow, someone actually understands how I feel. Is it possible the United Nations is actually saying this about us and about the way we are disabled? No matter how you can personally relate to this, another label, person with disability.
And in addition, in the UK, as people may know, there's been an inquiry into welfare reform, which has come up with great concerns about government. But of course, the issue then becomes one of what can the United Nations actually do about it. And in the case of that investigation, the government has done, I think, effectively nothing to put to rest the concerns that a wide range of disabled people, including mental health service users, survivors, have raised with the team. Any more final points of clarification in relation to Stephanie? If not, what I'd like to do now, this is what's on my programme, it says, is the panel discussion starts. But what I'd like to do, if people wouldn't mind, first is do something that's from outside the room, because we did have an opportunity for people who weren't going to be coming today, as well as people who were, to ask a question of the panel. And I wonder if it would seem all right to everybody else, as it seemed a good idea to me, if we could at least start with one such question, and then Kat might have some other things she'd want to feed into the conversation. But it's we've got loads of questions, and it's very difficult to work out which one to fix on. I'm trying to do this in relation to the kinds of issues raised by all our panellists, and I want to ask all our panellists briefly to respond to one such, which was particularly prompted for me listening to some of the things that Stephanie said towards the end. And it's a very straightforward, but I think very pertinent question. What can we do to change things? And don't forget, we are talking here about research and knowledge production, as well as about policy, if they do not want to listen to us. And it's that's the kind of question which I think, if you're 4 or 5, you ask, and adults are mostly too scared to ask. But it's the kind of critical question which we should be asking, I think. So let me start with Jasna. What can we do to change things if they do not want to listen to us?
This is not a suggestion, but this is the first thing that comes to my mind. I'm not proposing this. You can walk away and boycott. You can...
Just a little bit louder.
You can walk away and boycott and say, if you're not listening to me, I'm going away, you will not have involvement. This is difficult because people are competing for involvement. I'm saying, I'm not proposing this, this is just the first...
That'll do.
Option.
That's good. Stephanie.
Well, this brought to my mind directly the respect of the United Nations CRPD Committee for users and survivors of psychiatry, persons with psychosocial disabilities, who are able to engage in what they call a constructive dialogue with not only the members of the committee in charge of verifying that the treaty is implemented, but also with the representatives who are there from our own state. And so I think that maybe some third-party forums such as this can make it easier than trying to get the message directly across. And at ENUS, we often have talked about this whole problem with us versus them. And if we continue with this us versus them, we're not going to get as far as if we could actually listen to each other.
And Derek.
To me, it's about localism and activism. One of the changes, particularly in the NHS in the UK, which you might like or not like, is we're moving to what are called accountable care systems. And what it's going to mean is it's supposed to be based on services being designed about what's locally relevant to you. Now, there are lots of challenges with that, and you might not like that particularly. But it mandates that the services are provided for people around them and they're designed for people around them. And I think maybe it's easy for me to say it, I don't know in the position I'm in, but I think I have optimism that it's a good time to agitate locally, to get involved and to make noise locally. You should be talking to people, again I agree, it shouldn't be us or them. You should be talking to people in the services. Some of you may work in the services, you should be agitating. I started, and again, I like the organisation I work in, and I'm not fearful of speaking publicly about it, but several years ago I chaired a group that was called a patient experience group. There were no patients on it, it was staff. and there was a strange thing, that's just the way it had been. And I was asked to chair it, and I said, but how is this possible? And things can be changed. I take it's easier maybe for me to change out the position of management responsibility. But you got to shake the pram of it. I think people have to make noise and make noise locally. What I think is quite difficult is changing governmental level, because I think it's quite hard. But I think you start local and you get things shifted where you are. And I think services should be responsive. If they're not responsive, I think, do you walk away from it, do you make noise elsewhere? But they need to be hearing it.
Thanks. So actually what we're hearing is keep away, operate at quite a global level, or really operate locally. That there are some choices, is what that says to me. Can I just ask you, Kat, what's coming in?
I've got here, why is there inadequate research on the effects of coming off psychiatric drugs and the best ways of doing so? So why isn't there enough research on that?
Why is it not
Could you say it a bit louder, sorry?
Yeah. Why is there inadequate research on the effects of coming off psychiatric drugs and the best ways of doing so?
Would any of you like to respond to that?
Okay, I think it's coming on the research agenda. I think withdrawal is getting there. Why it wasn't popular? It's for all the same reasons why drugs are so popular, and coming off is not so popular. But I tried to say something about that. I thought about it a lot, and it's been a topic in Germany, and it's going to become another medical topic, I'm afraid. I mean, this is my personal, I have nothing against the topic, but the way it is, because I think drugs are being so criticized from so many sides, that now withdrawal is something to research and to experiment with. And my worry is that it will stay in the same realm, that there will again be medical dominance on this important topic. But
Before we move on to a response to that, could I just check with Andre if there's anything he'd like to feed in from outside?
Yeah, no,
I should say Andre Tomlin, who, as I mentioned before, not very positively, is the guy with the beard, and an information scientist, and one of the driving forces behind mental health. Please, Andre, thank you.
Thanks, Pete. I've got a beard today, no pointy ears, I'm afraid. I thought this question was really good, which came through Twitter. So why do psychiatrists seem so resistant to reduce antipsychotic doses when patients say they do not like the drugs?
Well, can we ask people here what reasons they think for that?
Good idea.
Derek?
Well, I feel the pressure as a psychiatrist to
That's as it should be, Derek.
As I should. Well, yeah, as I should.
That goes with the territory, I expect.
It does, and of course I'm not speaking for psychiatry, I'm speaking for myself with it. I think part of it is probably our training, and again, I think so. I don't know if people know this or feel it, or think, if you may not care. Most psychiatrists see themselves as doctors, as medical doctors, and that you might think that's a good thing or a bad thing, and then they specialise in mental health. And the training of doctors is inevitably quite conservative. And if you don't have to take the medication, but you prescribe it, it's a very different position to be in. And of course, I think this is part of the problem. And if I don't feel the side effects, if I don't feel the problems, well, the risk, how doctors see the risk is quite different to people taking it. So I don't think that's psychiatry. I'm not defending it, but I think that's probably the training is inherent conservatism. I don't want things to go wrong, and maybe there might be anxiety about being blamed if things go wrong. And then doctors don't feel side effects. I think that's probably part of the training of doctors. I don't think it's... people may have different opinions. I suspect if you're seeing a respiratory physician or a cardiologist, they probably never want to take you off anything because they worry about that. But that's not to justify it, and I think you need to be able to have conversations, of course, about coming off medication. I think there's conservatism in training and about trying not to cause harm by reducing, but of course we can cause harm by continuing medication as well.
And is there anything either of you two would like to add to that?
I'd like to add that this would be a good research question. That you go and ask them. And I think I could say something from my research experience, which was not on medication, but like community psychiatric services, residential. where there were lots of unnecessary hospitalizations of clients. Like they live in shared accommodation, and as soon as somebody shows symptoms of maybe getting worse, they get them into hospital. So we did interviews with workers and asked them, why is this? And then we got replies. And one of the replies that I could understand was, we go home, we are not there at the weekend, and we are responsible for what is going to happen. So in order to have my weekend, I'd rather have somebody put in the hospital than risk that they're going to stay there and something will happen, etc. So, I mean, this is just, I don't mean to defend them, but this is just a good example of how important it is to ask precisely this question. This is not asked. Why do you prescribe this much? If the person got all these things? I mean, this is what I meant with shedding light on those practices.
And Stephanie, anything you'd like to say?
I think it's also a question of trust. I think it's also a question of the very different relationship between psychiatrists and patients versus the relations patients can have with other types of medical practitioners. And I think there's a lot of, as we all know, there's a lot of paternalism, a lot of power involved in these issues. Also, a lot of fear of something happening to the patient, etc. I think that in any case, for me, it was really important to find someone who did trust me. And I trusted him. I trusted this psychiatrist. It was the first time in my life. I met so many that I did not trust before that. So I think that has a lot to do with it, trust.
Thank you. What I'd like to do now, trying to keep my eye on the time, is do what we promised to do, which is to open up the conversation to the floor. And that I think we did really mean it. I think McPin meant it. It wasn't just meant to be a question and answer session. It's meant to be a conversation. The only restraint I'd put on it is that we try and be nice to each other, even if we're trying to be quite clear cut. And we don't bring in arguments from other places, or be horrid in ways that are cruel and unfair, or reinforce inequalities that might exist. Now, I do feel a debt to Shula there, who wanted to say something slightly earlier, but could you kick off, Shula, if it's still appropriate, and then we'll really open up.
Could you ask them to
Yes, it
introduce
relates to
themselves?
that question.
Yes, could I do that? I've been helpfully reminded by Stephanie. Could people introduce themselves, and if they feel comfortable, tell us from what kind of vantage point, stakeholder position they are coming from?
My name is Shula Amon. I'm a research professor at the University of Hertfordshire. I've been doing research with service users in every capacity, from managing a project to being co-researchers and researchers since 1997. I would like to tackle the two last questions in particular. My sense is that the standing of experiential knowledge in our society is one of the main barriers to having a real impact. That as long as we believe not only in RCT, but there is objective science, and that type of science gives us more than experiential knowledge, it will be very difficult to break the barriers to using experiential knowledge. There is a particular theoretical approach that deals with it, and it's called the standpoint theory, that some of you may know, but many may not. And basically it's about accepting that all knowledge is situated. It's never ever objective. So I think that this is one of the major issues, that the knowledge the service users have is by definition, most of it is experiential.
And you think low valued?
And it's not valued as it should, which means as good as, at least, as the other type of knowledge.
Thanks, Shula. Can I start by asking...
Just finished.
Sorry?
I just want to say something else.
Please do.
The other element is to to this issue of activism, localism, pressure to listen, I think there is a way to start not only from research. I've been involved, some of you know, from 2011 in research on shared decision making around psychiatric medication. And what I've learned there is we actually need to give service users the tools to feel assertive enough to express what they have to say. This is absolutely essential, including those who believe in medication, those who do not. This is really a secondary issue. To being able to speak, if you want, to power or common power in a way that the other side can listen. And also that a lot of service users are not aware of alternatives. Not only the professionals are not aware of alternatives to medication, by which I mean, for example, the Hearing Voices Network, the open dialogue, that it doesn't have to be always medication, or it can be a combination of medication and. A lot of people are not aware. But also knowing where to find the information, to verify information, to decide on priorities. This is really the type of knowledge we have to make sure people have. I think the recovery colleges probably are the best place for it. But this is another discussion. But they tend to change mental health of psychiatry. It's not just psychiatry, but which we need to remember. It really has to come not only from research. Not because I don't value research, I do value research, and I see myself as a researcher. But because there are other key issues.
Let's turn to the panel then and hear some responses to that. And then I hope we might want to build on that and make it more open before we move on, perhaps to something else. Who'd like to kick off on that one?
I can. If not.
Yeah.
Yeah, I'll just say briefly on the first point, I disagree. I think experiential knowledge is greatly valued in society and in everyday life. When you look at who people ask and who people trust, those are people with first-hand experience. I think experiential knowledge has a great value in our everyday life. It is the science and the organization of science that does not value experiential knowledge. That's another thing. But like I just want to say I disagree with the first point. And with the second point, I also disagree. You said give people tools to express themselves. I think it's more important to give people space to express themselves, because I think everybody expresses themselves. And if anybody would need tools, those would be the professionals, like tools to listen, etc. To me, this is a foreign concept. Give people tools to express themselves. You said so that the professional can listen to them. I think it's professional obligation to listen to people the way they express themselves, and not.
Perhaps we should be giving different tools to the professionals.
Yeah, this is what I said. I think space is important. Give somebody space, give them time, and they will express themselves the best they can. And I think it's the professional who needs to have tools to hear, to see, and to hear, and to listen, and to respond.
Thank you.
And
Derek,
if I may,
Stephanie?
this also once again relates to the UNCRPD and to the whole notion of capacity and the idea of the will and preferences. The convention talks a lot about the will and preferences of persons being respected. So in order to do that, yes, you have to listen. And in order to understand what that person's will and preference is, including in other areas of disability, such as Alzheimer's or dementia, etc., this is going to be a huge challenge in the future for society, to find those ways to discern and listen to what people have to say.
Thanks.
I think in terms of the first part, I agree. It's a problem in research in that if you look at high-impact scientific journals, if you look at what people see as a hierarchy of evidence, it's given scant consideration. And I don't know how you change that, because it's the scientific literature, it almost feeds off, it self-perpetuates about high impact. People want to publish in certain journals, they take certain types, it self-propagates that. What's interesting for me at the moment in healthcare in the UK is actually, I think, and again, this is my personal experience in a part of South East London, is individual narratives are really important in shaping services. So what I find very interesting and positive is, if we're trying to develop a service and expand it, the best thing I can do when faced with commissioners is bring someone in who says, I want to tell you about my life and what just happened to me. And it's given utmost priority, which is really, it actually still shocks me to see that that's really quite powerful now. Now, that doesn't mean that you always get the results you want, but I think in terms of delivering clinical services, it's very, very powerful, which comes back to my point about activism and localism and saying, this is what works for us. I think about the second part, I think it's a two-way thing. I think organisational leaders at every different point have an obligation to have an opening to talk to people. And I think we probably do need tools to better hear and to be told to sit down and to be told to listen. I would support the principle of, does there need to be advocacy? I don't know, maybe some people, I can try to be very nice, and it might be very hard for people to come talk to me for lots of different reasons, for lots of different life experiences. I think it's probably not a one-size-fits-all. I think the organisations need to be ready to hear, and I think then there needs to be a multitude of ways that could be done. I think it'll depend on the person or people involved.
Thanks, Derek. Anybody else here picking up on this?
I'm Sam Robertson. I'm the EPI lead at Sussex Partnership R&D. I'm also a researcher and research user. I want to pick up on the first point that I've just completed my PhD, which was very much around orthognography. And so as a methodology, that's an incredible tool or method to actually work with lived experience. And I think in terms of sense that people aren't listening or we don't do things because it's not valued, I would counter that by saying we have to keep chipping away and actually continue to actually push those barriers and say, our work is valuable as well. But I remember someone asking me in a research group, how do we know it's your truth? Which actually encapsulates this whole thing. But for me, it's about one step at a time, to continually chipping away at this and actually saying this is valued as much as that is valued.
Thank you. Was Diana, were you wanting to say?
Yeah, I think that
Just a little louder if you wouldn't mind. A little louder?
Yeah, I'm Diana Rose. I've worked at the Institute of Psychiatry for 17 years. I'm a service user researcher. I agree with Shula about situated knowledge, but there's one thing that bothers me about this conversation is that it's very individual focused, and I think the whole idea of situated knowledge in Donna Haraway is that it's situated in collectivities, that the knowledge arises out of people getting together and thinking about and reframing how they've been taught to think about themselves. So that's one thing. There was something else. Oh yeah. So situated knowledge, but science is also situated. So the idea that you've got an objective neutral set of truths is what Donna Haraway calls the God check. Actually, science as practiced in the industrialised West is full of values, it's got its issue coming out of this and going forward. And it is situated in a certain type of culture, and the methodology that it uses, the epistemology is get the method right and truth to be rejected. And so I think it's wrong just to think that it's our knowledge that's situated. I think their knowledge is situated as well, and I think there is a case, if you can be bothered, from picking it apart, because actually there's quite a lot wrong with the way RCTs are conducted. If you sit in on meetings and see how what looks like a seamless story in a paper in a highly cut journal is actually generated, and is actually generated from lots of mess happening. And that underneath of that knowledge is something that needs to be investigated.
But I think, Diana, that you and the work that Shaw have done has emphasised and evidenced the points you're making now. But the word you didn't mention, which we all know is there lurking, is power and imbalances of power, which we take for granted, but which are incredibly significant and have a ruling role on how we come at the discussion, let alone on how we're likely to get dealt with by some of the more powerful discussants. Anybody else wanting to pick up on that theme or wanting to move us on, perhaps?
I'm Ruth Sazerbeck from McPin as a peer researcher. I just want to go back to the experiential knowledge and how it's valued. I was thinking back to, I think the problem is, because we've got mental health problems, our experiences are usually discounted. I was thinking back to a study I was on a panel for on the prevention of violence in secure settings a few years ago. And they were analysing violent incidents by asking the staff what happened. And I said, well, what about asking the people involved in the violence what it meant to them? Why, what sparked it off? What was the meaning of the violence? And they said, oh, they would remember. And I said, well, excuse me, but my experience of that is that it's one of the most chiseled experiences of my whole life, the memory of that sort of situation. Shouldn't you just at least try? But it was like, oh no, they won't remember.
Any thoughts about why they came to that straightforward conclusion in their own heads? Why did they think that? Why were they saying that? Do you know?
Well, a psychiatrist, I suppose.
They didn't want to.
I don't know. I mean, I was, I just thought this group was a long way to go, and they were writing the guidelines for best practice in prevention of violence.
So they were powerful.
Yeah.
Thank you. As is a momentary silence, is there any messages coming our way from beyond the room?
There's quite a few similar questions here, which are on the topic of what specific research studies would you recommend and how should service users be involved? So there's a couple of questions along that similar vein.
Panel?
Well, I honestly, the only thing I could say is that I've been very, very impressed by the work done by Jasna, by Diana, by Peter, by others I've only read about. And I have seen how often it seems like they have to go back to school and study for years and years and years to get up to that level where they can be taken seriously, just like any other official researcher, So in my experience, has been more, like I said, based on experience, opportunities, and I'm thrilled about it. And I would say that people shouldn't hesitate. Sometimes opportunities don't happen by accident, and I think that this happened to me for many reasons, and I'm thrilled. I'll see, but I think that any opportunity should be worth exploring. In fact, in France anyway, there is more funding available for even small research projects than for many other areas of our work and our action. So maybe that's also the case in other countries. I don't know.
And anybody else want to respond?
Not to respond, but to
Go on.
say something else. So there's quite a few comments on Twitter about the fact that research focuses on not, the general population of the world. Women are excluded, people with substance misuse problems are excluded, people who are homeless are excluded. So how can we kind of encourage research funders to actually fund real-world research in this area?
Could I just say a little bit about that? Because it's one of the personal and political interests of my life. And we carried out a big project in Shaping Our Lives. That's the user-led organisation I'm involved in, which we call Beyond the Usual Suspects, because we were hearing so often from people about how many people were being left out of schemes to involve people. And the irony was, of course, that not only were they being left out of the world, but they were being left out of the schemes that were supposed to stop them being left out of the world. And that they not only included all the equality issues, but 4 other domains of issues. That where people lived was something important, i.e. if they were homeless, if they lived in a residential institution, if they didn't have citizen status, for example, how they communicated, if they communicated differently, for example, if they were a signer, if they didn't have verbal communication, if English in this country wasn't their first language, things like that. And another one was if they were seen as, and we've heard it mentioned already today, if they were seen as too impaired, either to want or be able to contribute, which is a convenient one. And then the last one, which I think is great, because there is this issue, which we know McPin is going to pick up on, about representativeness, and you failing the representativeness test. But also we noticed that people tended to get excluded who wouldn't be expected to say what was required of them. And often this would be people who would not also be seen as representative because they had managed to keep going, you know, a bit like what I thought Diana was saying. I felt sorry for the people that she was encouraging to keep going, like myself, who wish at some point in their life they'd never had, because it's such a hard and painful business, often being involved. So people who would keep going and be assertive and determined and know how to do it, but wouldn't say what was required of them, were definitely another group who would be excluded, ironically. And I think that's really, really important. And you absolutely, one of the lessons from that research, which was locally carried out in different sites, was instead of waiting for people to come to you, you have to find all sorts of ways of reaching out to them and beyond what would be seen, for example, as their organisations, i.e. mainstream BME organisations or whatever it might be.
Can I come back? I wanted to ask Jasna, because you made the point in your report about people with lived experience having to kind of represent everyone. That's what you have to do, apparently. Do you want to say something about that? Because that really follows on, I think, from what Peter's saying.
A little bit. What it follows on is this difficult question that Kat read. You know, tell me what to research and how to do it. I think it's incredible. You know, I would be interested who's asking that question and why. You know, they lay back and tell me, because I think it's always a question of people who find each other, who find resources. They need to negotiate what interests them and how are they going to approach it. This is not a matter of, I mean, usually we are asked to bring in ideas, then sometimes you see those ideas in another version that they got funded by somebody. I mean, I'm kind of, if I had any such clever ideas, I would have written them in the paper, you know, what to research and how to do it, no smaller than that. I think it's a bit, and then when there's a concrete group of people and a concrete project and a concrete money, then I think it's really important to see whom we need here, who's missing, and how are we going to organize that they are here, because they should be. I think this is a question for each project, no matter whether it's research or whatever, to see who's missing and what can you do to bring them on board.
Diana, did you put your hand up for a moment there?
Yes, and Liz put, and I think somebody.
And who?
Liz also, and somebody here.
Well, should we start with you, as you haven't said anything yet, please? And just remind us who you are.
I'm Liz Wellman, and I'm currently working with Diana and Sure. And I've quite a lot of experience with youth involvement and being involved in research in Ireland before I came over here. But one of the things that really strikes me is and people have been touching on it, but I think to be explicit that power and freedom and autonomy to do your own research often is dependent on source of funding. And if we're in the privileged position of having money to do the kind of work that we know needs to be done to try and bring a group of people and services together to ask questions that are of most relevance to the people who've experienced the thing that you want to study. I mean, that takes time, and time is not always a luxury people have if they're not funded or supported. And I guess that's one of the big things, like what we get the funding is always goes into the scientific high impact, the kind of research that might get published in high impact journals, which is, as you pointed out, is a self-perpetuating and underpins the whole paradigm that we know doesn't address the reality that should be, that we know and that could be illuminated by, use another teacher for the microscope back on the time. I mean, you mentioned some of these issues in the report, yes, which is, looking at the prescribing practices and all of the issues that are around the social context that people experience around psychiatric medication, but people need resources to do that. They need resources of user-led groups, user-supported, user environments, because otherwise our ideas are captured and run off, as you just mentioned yesterday. People have an idea, and somebody else who was in a privileged academic position is able to write a very grant proposal again, and then so back to funding and resources for the user.
So I think you're absolutely right to raise this. There are mid-range structural issues, and I mean evidence, for example, some time ago, and it hasn't changed, that Shaping Our Lives pulled together really highlighted the structural discriminations that there are operating in terms of funders and user-led organisations. Very simple ones, very crude ones, and you can, you can be in a room with the funder and know where it's going to go, and it's even though you fight hard to deal with the sorts of things you think may be going around in their head, and it's only when sometimes there might be an accidental friend or something that you may get past that. That's assuming you can even get in a room with a funder, which it's incredibly difficult to do if you're not a high-status, high-profile organisation. Please.
Yeah, I was going to say...
What's your name, sorry?
Sorry, I'm Chris Chatterton. I work with McPin. I do copyright editing for them. I've got a lab science background, so I know from science, but I'm a medical sociologist. And Thomas and I were on a Department of Health basic research in mental health committee a couple of years ago, and I was shocked because Thomas asked me to be there as sort of an independent person, and I was shocked by how I come from a hard lab science genetic background, and all the guys there were talking about high-end projects, and I had to speak up from the social science background, and it was almost saying, social science isn't basic research. And I argue, you've got to have basic social science research, and talking about the situated knowledges, the field of science and technology studies, they've been banging on about how you construct medical knowledge for years, and I felt disempowered, and I'm quite mouthy and I would challenge, and that was within a committee of the Department of Health, and social science was being pushed down as an issue. So it's, as you say, it's a structural issue as well as the grassroots. And what we're saying about funding, if they're not prepared to fund it, you're scrabbling around for small amounts of money, and this work won't get done. So it goes right to the very top.
It is interesting. When Jan Walcroft and I did an article a long time ago about user-led survivor research, what we discovered was that the early stuff people had desperately managed to do unfunded.
Yeah.
That's how they managed to do it, because of just what you're talking about.
It's still going on.
Yeah. Did you put your... Thank you.
Yeah,
Just again, you're sorry.
I'm Rose Thompson. I'm from the McPin Foundation. I'm a researcher here, and I support quite a few other researchers. And one of the things I want to say is about people with physical disabilities, and the reason quite often they get excluded from research is because it can be hard. And I think one of the examples I think is that we have a researcher called Richard who is now going to do a PhD, which is brilliant. But when we first started working together, Richard is a wheelchair user. He has limited mobility in his hands. He can't actually type. And I didn't really clock early on that he finds it difficult to type, and gave him a few bits to do that actually he couldn't do. And I think over time we basically worked very hard on our relationship so that we could work out what he could do and what he needed help with. And that relationship between the two of us became very important in enabling him to be involved in directing the project, in making decisions about where the project went. But you have to invest that time and that effort in making a project work for someone where there are physical limitations in that way. You can't, and I think there is an issue in that a lot of kind of more mainstream researchers don't necessarily know that you need to invest that time, or don't want to spend the time working out how to work with someone who might not look like a traditional researcher who finds it easy to sit at a computer and bash out a bunch of words. So,
But here I think it's helpful that we remember there actually are some levers, and that there may well be many researchers who don't really feel like doing it, but the law is against them, and they can be taken to court, and it's a complex business. But people do have a right to have reasonable adjustments made, as I've had made in my university, for me to work on equal terms, not about something other than that, equal terms. So we have got some levers, and sometimes we don't know enough about the levers ourselves, and it's important we do, and also that we communicate that message with some force to those who may not want to know about it. Thank you.
I'm not sure if this is...
I really feel boring doing this.
Jenny Parker, I work from McPin Foundation.
Thank you.
I'm not sure if this is a question or an observation, but I'm a service user researcher, and I work mainly with personality disorder. And I haven't taken any psychiatric drugs for probably 10 years or more, and I never would. But I'm thinking about the link between diagnosis and medicating, and how it's a bit automatic sometimes. So I think when I was depressed, I had one thing. When I was bipolar for about 3 months, I was on lithium. Then when I had personality disorder, I was on mood stabilisers, I think it was. But now, obviously, the NICE guidelines changed, so I'm not on anything, and I don't want to be. But I think it'd be quite interesting to talk to psychiatrists and actually do a qualitative study on how you decide what to prescribe, what actually leads to that, and what service user involvement and how collaborative is that process. I don't know whether anybody's been through that experience. It's very hard to actually speak up for what you want in that situation and to be listened to, because the ECT was another thing that I had because I was depressed when I actually wasn't. And so that's quite sort of difficult retrospectively to think about.
Do you want to say something, Derek?
Yeah. I think it's a really good question. We did a bit of qualitative work a few years ago, where we were doing work with people who'd been given a diagnosis of borderline personality disorder, but they originally thought themselves that they had a bipolar affective disorder. And they came in and we talked to them about what did it mean and why did you think you had a diagnosis, or what did it mean to be given a diagnosis, kind of understanding meaning and treatment. And the thing that just came out to me was you can't pigeonhole and say, to me it's bad practice to just algorithm and say, right, we've scored you depression, so therefore it's got to be conversations with people. I've spoken to people who've been given a diagnosis of borderline personality disorder who said to me medication was a helpful thing for a point in my life and I was glad to have access to it. And I've got people who said, that stuff knocked me out, why was I given that and why was it not explained to me? And equally with borderline, with bipolar affective disorder, I mean, it comes out as such a fundamentally obvious thing that doesn't happen enough in practice. It's just talking to people about. So to me, it's about not getting lost in a diagnosis. A diagnosis can have value at time, it can help, but it can be challenged a lot because I think it can presume a very binary understanding of something which is actually really fuzzy. Medication can help or cannot help, and the problem is thinking they're two very fixed, certain boxes that can be joined by a strong line, which they can't. So my only thought would be an individual practice. I'm not saying this for psychiatrists everywhere. Is my thought would be, tell me what's important to your life, and tell me how you're feeling. I'll try to think with you about what we have and what might work and what might not. We should try and do what seems reasonable next. What's good, we'll stick with. What's not, we stop. But I think it is problematic if there is an automatic joining. You are, you. This means, and I think that's a problem about kind of presuming. I know it's a bit of a fuzzy answer, but I don't think that there's
It's helped because I'm just thinking about another piece of work I'm doing at the moment, which is removing the bio and looking at the psycho and the social as interventions for personality disorder, and that's all qualitative work that I'm doing with someone else in the NHS. And
So the people that are in the active arm of the trial are getting 10 sessions of psychosocial support and psychoeducation, which is brilliant. People who are in the treatment as usual group are having medication review. And I think these are all people who associate with personality disorder, and I just find that so shocking. That's the treatment as usual.
And name medication review, I would hate it. I mean, it's just such a dreadful thing for, I mean, as a psychiatrist, that's a dreadful thing for me to be told. I mean, it must be so much worse to be told you go to see a psychiatrist for medication review, but I find it offensive to be told someone's in medication review.
Well, it's not what the trial stipulates, it's because I'm interviewing people going through it. That's what's coming out of it, is they're having basically treatment as usual as nothing, apart from seeing a psychiatrist every now and then and having a medication review. And that's obviously not everyone.
Would either of you two want to say anything in response to the issues raised there?
Well, I think this goes back to what I said earlier about it really being the area where consumers have the least choice, the least amount of things to say in any health sector. And what Liz said earlier about funding, and this really concerns me, worries me, because the UK is much more far advanced than probably any other country in the world when it comes to this type of research, survivor research, true survivor research. What I see happening in France with these, research action programs, or these people who users and survivors of psychiatry who desperately want to work on things, who want to do things, are ending up being instrumentalized by researchers, used by researchers, giving their little testimony or other, and not really empowered. And I think this is a huge risk.
Thank you. Please, Diana.
Can I just say something about this idea that the UK is rather advanced than any other country in the world? Is it actually commonly Australia, Norway, some parts of the States? Not to damn it, but the kind of involvement in research that is encouraged and funded in the UK is involvement in mainstream methodology. You don't have a chance to alter the methodology. Therefore, you can't really alter the results. So you can do things around the edges, you can tinker around the edges. I think many people have got disenchanted with that. And I'm not denying it, because it has had some effects. Got disenchanted with that and moved to things like medical anthropology, sociology, other disciplines to frame things completely differently. And then once you've thought about it differently and distance yourself from that, those forms of methods, then people do different settle the issue of funding is funding. The first piece of user research I was involved in, there was no money, we just did it as a user group. Well, that would not did it.
Could I just go back again now to Kat and also to Andre and see if there's anything that people would like to feed in from outside?
I've got a question here. Why are service users diagnosed with schizophrenia so rarely offered any alternatives to psychotropic drugs? Why are service users diagnosed with schizophrenia so rarely offered any alternatives to psychotropic drugs?
And what about you, Andre?
It's a lot of it is about withdrawal. I think that's been a real focus of the questions that have been asked. Why is there so little research on withdrawal? We know quite a lot about withdrawal, but we're not implementing it in practice. And yet, obviously, alternatives to psychiatric.
So could we try and ask our panel to look at those two kind of related things, but different? And then there's somebody at the back who I'll come back to, if that's all right with them, after that. Jasna, would you like to start?
My God, the first question.
These are all my God questions. They're all huge.
My diagnosis. Okay, I better not talk about the diagnosis. I don't want to produce more enemies than I will have with this. It's a kind of diagnosis that gives you a green card for that kind of treatment. More, but it touches on the issue of diagnosis. With withdrawal, my thoughts on this are the same. I think one drug cannot solve the problems. I think it cannot solve all the problems that people bring in. Also, taking the drug away only as the only intervention or reducing it is also not going to solve the problems. So I think, of course, it should be researched and people should be supported, etc. But the whole thing, I mean, the whole idea of treatment and response to madness and distress is about chemicals. So either giving them or taking them away, I think so much stays outside of that room where that is happening. And I also don't think that it can be resolved in that room unless people are really privileged and the only thing they have is some, you know, they want to talk about some things that bother them a little bit, etc. That also exists, and they should have a right for those kinds of conversations. But like you come in there. I recently had an interview with a survivor activist from US, and she said, if you imagine this being the case with HIV, that everybody who comes in get the positive results, it would be a tragedy. It would be alarming. But like with psychiatrists, everybody who comes in, they come with a positive result. That's so. Okay, about withdrawal, I'm nothing against withdrawal. I just don't see how it can happen only with medical intervention, because something else also needs to be tackled or to change or to be looked at, because the problems people come with, including what is called schizophrenia, are not in their bodies and in their, only in these individuals. They bring all sorts of, we all bring all sorts of issues. So I don't mean to say drugs are minor problem, not at all, but it all focuses only around that, and now we will have a new focus which will attract more funding. But the problems will still stay, because I don't think that this profession and this kind of approach can ever resolve them. That's my personal stance.
Stephanie?
Oh, very briefly, I think it also has to do with the responsibility of the pharmaceutical industry and the increasing risks, problems, class law action suits, and everything else going on. That would be about high time that they took on some responsibility to train doctors to de-prescribe, and that doctors take on that responsibility beyond simple medical assistance at withdrawal in terms of quantity. As you're totally right, Jasna, it requires a lot more than that. So perhaps that, combined with the greater realization of people that there are alternatives, because it is true that they often are unaware, could lead in the future to that much better situation. And if we rein in the industry and hold them to be accountable better.
And Derek, thank you. Thank you, Stephanie.
I think with regard to psychosis, I mean, it would be a very poor service, and it would be against national guidelines if they didn't, if all they offered was medication. It's not what we're meant to do, and psychiatry is one part of mental health, and mental health is one part of healthcare, and healthcare is one part of society at large, and there's a limit to what medication can do, and it would be bizarre to think otherwise. Medication can help lots of people, but if you think about mental health services, there's an obligation to look at talking therapies, family inclusive practice, and so forth. You mentioned at the start, I'm involved in that as a trustee of that charity, and one of the best things we do is we get young people out and we get them exercise. It's non-contact, it's just out doing exercise and boxing. I wish I had a medication that worked as well as that. I don't. And one of the best things I ever saw on the ward when I was a junior doctor was when they brought in a beautician onto the wards, and I thought, I wish I could make people as happy as this person can make them feel happy. So I think it would be an incredibly narrow viewpoint to focus on medication. It would also be a mistake from my point of view to disregard them for people, and I think it's an option within a menu, but it goes against national guidelines to just have that. The issue about withdrawal, I mean, I'm not a psychopharmacology researcher, I'm primarily a clinician and a manager in the NHS. I suspect the issue is that it's largely funded by the pharmaceutical industry, and that's not their... it's not what they look into. It's not what drives them. So then looking into withdrawal, I think is hugely important. I think better education of doctors and training doctors would be highly valued, because I think it's a massive problem for lots of people. It's not been a research priority from what I can see. It's not where the money goes. And this comes back to the earlier point about what gets funded and what doesn't. And there's a real disparity about what research has been seen as valued or important. And just one last quick thing.
Profitable.
Or profitable, yeah. One last quick thing, just a quick plug. I work in a crisis team. Most people in the team I don't diagnose. You don't have to have a diagnosis to have a crisis. And interestingly, actually, I was talking to colleagues from Germany, and they have a difficulty in their home treatment teams because if they don't give a diagnosis, the insurance won't cover it. So they can't see someone without a diagnosis, which feels quite perverse. To have a crisis is not a mental illness. A crisis is one of those things that happens. So I'm very happy to see people and never diagnose. It's a nice thing to do.
Thank you. And gentleman at the back.
Dan Merrill, I'm a researcher at the McPin Foundation. I wanted to talk about that withdrawal. Actually follow on a little bit on what Derek said. There's something in the paper, actually there's quite a lot punctuated around the paper around the system of research, i.e. the funding, the industry, business and research. And I think that's absolutely right. I think things like the withdrawal are not very fundable because they're not seen to generate patents, they're not seen to generate industry in the way that the research system is working now. I should add that before working at McPin, I worked in Biomedical Research Centre at the Institute of Psychiatry. So I saw quite a lot of how it worked, if you like. And we did a priority setting exercise to Sally and Diana sitting here around what service users and carers wanted from research, and building on other similar priority setting exercises. And these were things like looking into polypharmacy, looking at the reduction of medication and reducing side effects, how to reduce side effects. There was nothing really about new medication or anything like that. Unfortunately, all of these things which are high on services lists are not very business focused. They don't generate income and patents. They don't flow around the research system in the way that sort of biomedical research systems would want.
Did you particularly want anything back from Jasna about that?
Not really. I just thought from your paper, I thought this was something that came out. You hinted this the system, if you like, which is sort of changing or overturning the system with new idea.
Diana did put her hand up.
Yeah, I just wanted to add something about that exercise. One of the things is come up slightly already. One of the things that happened in that very decision exercise, when we went to about 10 service user groups, we didn't reach any people from BME communities. So we then did a separate exercise working with a local one organisation, Kindred Minded in Southwark, and asked them for their research priorities. And one of the research priorities that came out of that exercise was stop using us as guinea pigs, research yourselves. And I think this is an issue, we talk about excluded groups, but it's like we don't talk about our privilege. We don't talk about the fact that there may be racism within the community of service users by the researchers, and that's why we want representatives in our community. So I think we have to take that on board.
I think we do, and I think we have to remember, somebody taught me this lesson a very long time ago when he drew a distinction to me. He gave a lovely example between involvement for empowerment or involvement for extraction. And I have seen too much of involvement for extraction, especially in relation to black and minority ethnic communities. I know of somebody who recently died tragically, a very famous person, who at one period in her life was in charge of a major social research project concerned with involvement. And she recruited a white staff and then noticed that they weren't doing too well with the significant black and minority ethnic population of the locality they were based in, and therefore, of course, recruited a really nice young black woman to take on that task. when you spoke to this unfortunate person, what they were meant to do was to draw the people in who would then get dealt with in exactly the same way as they would have done anyway. An absolutely specious project which acquired enormous fame, as is so often the case with the inverse proportion kind of way it works. We're coming up to 4:30. We have to finish at 4:45, and what's been suggested is that we let Jasna have 5 minutes to respond and maybe take us forward with the discussion on the paper, and then I'll make some brief closing remarks, and then maybe we'll have a final quick chance to just check out from outside the room, but I'm determined to stop on time. Over to you, Jasna.
This is the most difficult for me, the most difficult moment, because I don't know if I didn't prepare. I mean, I knew that this would come, but I didn't really prepare, so I don't know what clever do I have to say. Okay, there is one thing that I did not mention in the paper and that just came now, and that's the industry and the pharmaceuticals. And Stephanie used the expression responsibility of pharmaceutical industry. I don't see such thing. So the paper was directed to everybody else. Because, I mean, the fact that I didn't mention it doesn't mean that I don't see it everywhere. But I try to write a paper for those people who are ready to, you know, to look away from that, from the interest, from the profit. And I can only say that I hope that there will be more people working in research and in practice and in survivor movement, etc., ready to look for other responses. I really think this is a huge question. What to do with madness, with different sorts of madness, if not calm down and eliminate and out of sight. This is a huge question. And I think this is where our efforts should go, in exploring that. And I don't think that new inventions are needed. There have always been other systems of support in place. They are there, but I think there needs to be much more use of that. So this is what I would hope for. I would hope for current drug research not to receive more funding. That would be my hope, and that the funds are directed towards exploring really what could be done in different sorts of situations. How can communities be empowered to deal with these experiences together? And not in specialized relationships.
That's it. Thank you very much, Jasna. I just want to say a very few I think they're contextual things. First of all, using first-hand experience, not my own, but lived experience, I want to refer to the experience of my partner, which I do think is material, who's currently working as a welfare rights worker with older people defined by the organisation as people over 50. And that means, which is one governmental definition, but it means she's effectively dealing with two generations of people. And one of the things she said to me, because every night we have this chat about what you've done and who she's seen that day, and it's shocking actually. One of the things she's talking about is going into people's homes and perhaps talking to the person who's making the application, but there's somebody in their family who doesn't come out of their room, where there are curtains drawn, where the person's able to do less and less, and where there is absolutely no support for any of them. And it reminded me of when I bought a new bicycle when I was young, and I put an advert in the window of a shop, and then somebody responded, and I went to see this person, and this is a very long time ago, and he had been a relieving officer. That was the equivalent of a social worker under the Poor Law before the Second World War. He was a really lovely bloke, a socialist, he told me. And when he hadn't got a job, he thought, well, where will there be jobs? There'll be jobs for people who haven't got jobs, trying to sort them out. But he said to me, part of his responsibility was in relation to what was then the lunatic asylums. And he said that one of the things he had to do was he had to go out with what was called the ambulance of the Metropolitan Asylums Board in London to people's houses to collect people who were going to go to the institution. And he said, and these were his words which have been indelible in my head ever since, but the time we would get there, they would be raving. Their families would have done everything possible to keep them out of the institution, which we have some inkling of from history of what those institutions could be like, and they weren't all the same. And they'd have no support, and things would be terrible. And it seemed to me there was a connection coming here between what Susie was reporting idiosyncratically and what he had told us, which is we know we are living in a welfare state that's being run down, where whatever emphasis, and there isn't much, is on control, where welfare benefits have been attacked just as much as services have been attacked. And I think that this is really important as our context. And the other context I think it's very important to mention, which I feel has been touched upon, is that most of us, until something goes wrong, unless we're very privileged, tend not to get involved. I've seen unbelievable examples of involvement. I've seen working class people in Liverpool who got together after the body parts scandal when children of theirs had, do people remember this? It happened in several places where instead of their bodies being buried, they had been used for medical research. And in fact, some of those families had 2 and 3 funerals for the one child as the bits were found. And the level of skill that those people had developed together to combat what had been done to them, which we can all develop when it happens to us. So I think what Diana said about collective involvement is desperately important, but most of us start from a non-base. Very few people get involved in our society. We might get involved in kind of like pleasant voluntary activities or bicycle clubs or whatever, but not what we're talking about today. And that's really, really important. And the other thing we have to remember is that the kind of organisation that people find most comforting at a personal and political level in terms of its effectiveness is self-organisation, and the evidence undoubtedly is that self-organisation is the most penalised form of voluntarism and is going through a particularly difficult time. And I'm not articulating any of these points to discourage us, but merely to be clear about the ground we are treading and that we are needing to deal with. Because people have rightly talked about power inequalities and discrimination today, and it is the currency of the world that we're trying to change. But I do think we're getting blueprints, and I think there was an enormous amount of almost taken for granted consensus here today and outside. Quickly, any things that you'd like to feed in from outside?
We've covered quite a lot there.
Thanks. And what about you?
No, I'm good.
Well, in that case, can I just do the honours? First of all, and I really valued the contribution all 3 of you have made. Could I dare say I might not have expected to be all 3. I've got prejudice against psychiatrists, which I'm working on, and which psychiatrists like you help me to work on successfully. So thank you, Derek. Thank you, Stephanie. Thank you, Jasna. Thank you, 2 of you, for making long journeys. Thank you, Jasna, for going through all the trauma of the journey you've gone through. I'm really pleased you've been here. Thanks to all the McPin people. Thanks particularly to Kat and to Thomas and to Andre and everybody. And most of all, thanks to people not in the room who've been part of this, and to people in the room who've made it have meaning. Thanks, and I hope that there are next steps. I really do hope that in McPin tradition, things keep moving on. Thanks, everybody.